Okay, thank you. So the top 10 barriers to tomorrow's payment models and the customization of the medical home. During the course of putting together the toolkit, we interviewed a whole bunch of folks that are working on integrated care. And those interviews turned into identification of barriers and tips for how to overcome those barriers. But what we found was that there was a consistency among what folks in California were experiencing with the literature, that the small amount of literature that's out there about how to get paid for integrated care. And I want to underscore small amount because there hasn't been a lot that's been written. There's really just 2 or 3 things that have been put out into the public. Something developed by the National Council several years ago, something developed, funded by SAMHSA also a number of years ago, and then some unpublished material, and then this toolkit. So the purpose of writing the toolkit was to try and fill the gap. We're not going to talk through every one of these barriers, but I do want to talk about some of the key ones and create an opportunity for you to ask questions about other barriers or questions about the specific barriers that you may be running into. One of the things that was actually a little bit surprising for me as we were doing all this thinking about the walls that people were running into and how they were overcoming them, is that there's the conventional wisdom is that, at least in some parts of the country, is that the Fqhc should just take over running the behavioral health for folks with mild and moderate disorders, and they don't really need the specialty behavioral health system. The specialty behavioral health system really is just for folks with serious and severe disorders. But what we found is that there were significant barriers to getting paid on the health center side, and that working together using the partnership model of bidirectional care, as I'm reading here from the slide, is actually the best way to get paid, as well as the best way to manage complex cases in the current environment. And so what I mean by partnership model of bidirectional care is that that's kind of a technical term that means that a health center and a behavioral health center or a mental health center come together, and they're 2 separate organizations, and they say, we're going to create a partnership to work together to support each other with the behavioral health and the health pieces. And so what's happening is that those 2 organizations are tapping into 2 separate funding streams and are able to braid and blend them together in a way that they're able to work around the difficulties in either of the funding streams. What this does is it leverages who works where to get paid. And so this is one of the other sort of meta ahas that we stumbled across when we were doing the project, and that is, as it says here, strategic employment of behavioral health clinicians either in the behavioral health center or in the health center. Who their employers are can make the difference about whether you get paid or not. And so we're going to be digging into some of that stuff. But again, that somewhat conventional wisdom that the health center should just hire behavioral health folks and live happily ever after is turning out not to be true. That sometimes you absolutely want the behavioral health clinician to be working for the behavioral health center in order to get paid. And again, I'll be going into details about that. And so I'm just repeating myself here. There are many instances in which behavioral health clinicians working for the behavioral health center, stationed at the health center, is the best solution. So let me underscore that the behavioral health clinician working for the behavioral health nurse station at the health center is the best solution for getting paid for those kinds of services. Let's dig into some of those barriers now. The first is health center billing of mental health and substance use services. I'm having a little bit of response time problems with my computer here, so just a sec. There's a set of rules that's fundamental to a health center, and if you've worked with health centers or worked in a health center, you'll know all about it. It's called a scope of project change. And anytime a health center does something new, which includes changing the services, the sites, and or the providers, there's this formal process that it needs to go through with the feds to create a change in scope. It sounds simple, but unfortunately, in California, it's become a lengthy and complex process. And it actually takes longer in California to get a scope change than it does in a number of other places. And the other piece is that when you do a change in scope, it opens a Pandora's box for the health center, as I mentioned here, of rate review. And let me see if I can explain what I mean by that. In around 2000, prior to 2000, I think it was prior to 2000, if you're a community health center that received federal funding, you filled out a cost report, kind of like the short automatics, and they went to something called the Prospective payment system. And the Prospective payment system said, here's the deal. From now on, what we're going to do is we're going to take your 1999 cost report, and we're going to pay you in 2000 and 2001 and 2010, 2011, based on your 99 cost report adjusted for inflation. And if you make a change in your scope of project, we need to review the rates. And so you go. So I'm sitting here thinking, oh, well, that's great. So I'm going to add behavioral health services, and there's going to be some of the things that the behavioral health clinicians are doing that we can't get billed for, and that will get built into the cost basis. And so I'll get paid for that. But what's actually happened over the last 10, 12 years is that there's a number of health centers that continue to get their prospective payment system adjusted, but there were changes in staffing patterns. For example, they started using more nurse practitioners or physician's assistants than they had in 1999 that brought down the cost of care, the actual cost per unit of service. And so some health centers are concerned that if they do a change of scope, if they integrate behavioral health in, which means adding a new service or a new site, or both, they're going to have a rate review and they'll have to do a new cost report. They're afraid that their unit costs will go down. And so when I say Pandora's box, there's a small number of cases. We don't know exactly how many this affects, how many health centers this affects in California, but there are cases where health centers' rates could go down. So you may, if you run into some resistance about this rate review stuff, that may be part of the problem, and that it is a Pandora's box. So the deal is before you can start getting paid for, so let's just say that you're going to embed a behavioral licensed clinical social worker working for the mental health center in a community health center to provide mental health services to the patients in that clinic, and you want to bill through the health center's prospective payment system. Then before you can, it's really kosher to start billing. You need to have that change of scope filled out, submitted, approved, and then it's backdated to the date of the application of the change of the scope. So that's how the process works, and you don't want to jump the gun and start billing through the health center when you're not going to get paid for the health center. So this is a very, very important thing to be aware of, and everybody in the health center world knows about this. So to the degree that you're dialed into this will help you as you're becoming best friends with the health center. Now, there are limitations on who can bill for services, and again, I know that a number of you are probably familiar with this, but HRSA, the Health Services Resource Administration, which is the federal government branch that oversees the health centers, there's these regs, and the regs are the regs are the regs. And right now they say that behavioral health providers that can bill for services are psychiatrists, psychologists, psychiatric nurse practitioners, licensed clinical social workers, period. Now, there's some, for those of you that are familiar with Medicare Incident 2 billing, where there's a nurse that's billing under the license of the doctor, there's some potential for doing Incident 2 services, but it's a very big gray area, and there's not I haven't seen anything written that says, yes, it's okay to do that, and no problem, go for it. So, generally what folks are doing is they're saying, if the clinician type that we're embedding in the health center is not one of these folks, then generally we can't submit encounters for those services to Medi-Cal through the prospective payment system and get paid for that. And the payment model is, when they did that whole prospective payment system, they basically say, let's look at all the services in the clinic and let's come up with a single per visit, per encounter rate. So unlike short-dose Medi-Cal, where there's a per minute rate for each different type of service, this is a fully loaded, blended average rate per hour, regardless of whether it's a social worker that's doing it, or a nurse practitioner, or an MD, or et cetera. So the billable folks bill encounters, and then everybody else's costs, the costs of the receptionists and the medical assistants, et cetera, gets loaded into the cost just like you're doing a cost report. What happens is that, so thinking about this limitation, Elizabeth Morrison at Golden Valley, what she basically says, if you're faced, so what do you do if you don't have LCSWs that you can embed in the clinic? And so one of her ideas was hiring clinical social workers who are working towards their license, fund them through grant dollars, and then shift their billable funding, their funding to billable services when they become licensed. And so this is a way to attract people to the community to work in the organization, deal with some of the workforce shortage issues. And what a lot of folks are doing are using MHSA funds to cover these gaps. This is really the big savior in California for these integration projects. And so this is a strategy, this is a temporary strategy where you're on the way to getting folks who are not billable to become billable. The other thing you can do, of course, is have folks who continue to be employees of the mental health center or the mental health department, bill through short-dose Medi-Cal, and simply be stationed, outstationed at the health center, working at the health center, working for the behavioral health system, billing through short-dose Medi-Cal. Again, there's a place for questions if you have any questions you want to pose, or you can raise your hand. And when we get to the place where we're doing Q&A, which is a handful of more slides down the road, we'll stop and talk about that stuff. Let's see, the latest question, can providers who can't bill work under the license of the bill provider provide in-situ service? We already talked about that. Some places are doing it. Some places have taken a more conservative approach and are not doing it. And because I haven't seen anything definitive written on this, I can only be as clear as mud about whether you should go for it or not. Let's talk about barrier 3, psychiatric consultation to a primary care provider or care manager. So if you think about the impact model, where the team in the primary care clinic consists of the primary care doc, the master's level clinician, hopefully who's a licensed social worker that can bill, a consulting psychiatrist. The consulting psychiatrist is consulting to the primary care provider or the care manager. And the deal is that that's not a billable service that's not an encounter. It's not a valid encounter for the health center. But of course, as Louise pointed out, the mental health rules allow for these types of phone calls and pay by the minute. And as it says here, this solution, however, requires that the consult is coming from outside the health center. So the person has to be working, the psychiatrist has to be working for the mental health center or the county mental health department. But it's important to note that that kind of psychiatric consultation where the patient isn't present is not a billable encounter through the community health center system. So this points out, as the screen says, there's a solution, and the solution is to be careful about how fully you've integrated your system. And I know I'm repeating myself, but it's important. If everybody becomes an employee of the health center, then you end up, and you think about what are the services that are needed in an evidence-based best practice model, like a psychiatric consultation, you're basically shooting yourself in the foot. Again, if the consult is coming from someone within the health center, it cannot be billed. If it's coming from an outside specialist, even one based in primary care, it can be billed. We're starting to get some questions written in. That's great, and I'll be stopping in a couple minutes to visit those. Back to this slide here. The psychiatric consultation can be billed to short-term Medi-Cal under specialty mental health. It can be if the person is working for the mental health center, and if the person is working, if the psychiatrist is working for the health center, you can use MHSA dollars for it. So what people are basically doing, if you think back to the last week, if you were on the call, is you design your workflows, you decide who works where, you take your first shot at deciding who works where, and then you think about all the services that get provided to clients, and based on your staffing design, who can bill whom, and you figure out whether that's the most effective way to do it, and if not, you tweak your clinical design, including the types of providers you use and where people work. Now, there's another problem that people are running into is, in addition to not being able to get psychiatrists to bill for non-face-to-face consultation, there's actually a lack of codes for a number of things, including that consultation, including care management, and including screening, brief intervention, and referral to treatment. The CPT manual, if you dig into the medical CPT manual, there are 3 sections that have a whole bunch of codes related to behavioral health: evaluation and management, psychiatry, and the health behavior assessment codes. One of the problems, even though these are in the CPT manual, they've not been turned on. The payer basically has to say, okay, you can use 99211, 99408, or 99409 for doing that expert service. And if the payer hasn't said we're going to pay for those services, i.e. turn them on, then you're not able to. Then it's as good as not having the code. So this really should be lack of codes that are payable by a given payer. Is the problem here. And there aren't any CPT codes for non-face-to-face services. And also, California health centers can't bill for group, which is really kind of bizarre. What it's really pointing out is that the billing system for the community health centers has a lot of good things going for it through the prospective payment system, but it's really a very outdated system when you think about what a modern healthcare system requires to provide holistic care to help people move towards health. It's really not in sync with that. Now, someone asked a question around this slide. An RN as care manager is not billable under the Federally Qualified Health Center, the Fqhc. And basically, what some centers, so theoretically, theoretically not. There are some services, some folks that are attempting to bill the RN as an Incident 2 service under the direction of the doctor. But generally speaking, what happens is when RNs are actually able to bill for services. Sorry. So if the code is turned on, well, let's see. I'm sorry. I'm twisting myself up because there's actually 3 things that are going on here. Sometimes the feds will reject a claim for a mental health service when a doctor provides it. Sometimes they'll reject a claim for a mental health service when an RN provides it. Care management codes that RNs can bill for that can get billed through, but there's limitations to that, and there's some barriers to that. So it's actually part of the process of designing your creating your design and doing your workflows is to sit down and to say who's going to be doing care management, and actually literally come up with a checklist of the codes that are used. What I'm going to do is one of my follow-up homework assignments is to pull the codes that RNs can use when an RN can and cannot bill care management, so because I'm being not as clear as I want to right now. And my apologies for that. Two more barriers I want to touch on, and then we'll see what other questions folks have. Barriers to team-based care and the same-day billing restriction. You cannot bill multiple providers for the same visit or multiple visits on the same day in a health center unless one of those visits is a dental visit. You can't bill 2 medical visits. You can't bill a medical visit and a behavioral health visit on the same day. Now, that's actually a California law, and there have been attempts made in the legislature for the last several years to put forward a bill to get that law changed to allow there to be a medical visit and a behavioral health visit on the same day. And as it sits right now, that it hasn't gotten anywhere, because and the reason why is because there hasn't been a convincing case to the California legislature that that's more efficient and will save money. People just see it as dollar signs and increasing the costs for a state that has a huge budget hole. So what people do generally, let's see, what people do, and let me just fix this, is they adjust the PPS rate, and I'll explain that in a minute, but I want to fix the typo. What you can do is you can adjust the PPS rate so that if there's a lot of psychiatric or behavioral health services that are being provided on the same day as a medical visit, you build the cost of those behavioral health visits into the into the overall encounter, because remember I said that the encounter rate is the average cost of the billable services. So if you add another $50,000 of costs to the center for behavioral health services aren't billable, you can change the PPS rate so those services, the cost of those services get spread out over all the billable services, if that makes any sense. The other thing that you can do is use the behavioral health center. Excuse me a minute while I get my questions up. Again, barriers. It's really important to be as meticulous as possible about who's billing what and have that plan done in advance. Let me go, no, I'm going to shift gears and actually I'm going to put myself on mute for just a minute, give you all a chance to think about if you have any other questions. There's some questions I haven't answered yet. And I'm going to come back in 60 seconds and field some of the questions that we haven't covered yet. So I'm going to go into my cone of silence right now. Okay, I'm back. Can an MA or health worker bill for care management like an RN can? No. Generally, sort of the simplest answer, the most straight. Let's see. The answer that seems to be what most people are agreeing upon is that an MA or health worker cannot bill for care management through an Fqhc, so that needs to become part of the folded into the cost of the rest of the encounters, just like a front desk person's costs would be folded in. There are a small number of cases that conversations that I've had with people where they're exploring billing Medi-Cal as a requirement that the service provider be a licensed clinical social worker. Can they be an MFT or an intern? And you can't bill through the prospective payment system if the person is a marriage and family therapist, or if the person is an intern, including a clinical social worker who hasn't gotten their license yet. So what a lot of people are doing is they're either billing through the mental health center, short-term Medi-Cal, or they're using MHSA funds. And that's why this partnership model is so important. If billing Medi-Cal does the assessment need to be as complicated as a specialty mental health, which is often a real pain in the neck. And what I've talked to a number of mental health folks who have had these really interesting conversations where psychiatrists have sat down with medical doctors. The psychiatrists work for the mental health center, the medical doctors work for the health center, and they brought their forms with them. They brought their assessment forms with them, and they basically shared notes. And what you basically have is a very streamlined assessment process that is, let's see, I don't know if this is an accurate way to describe it. It's highly unregulated in the health center, and a highly regulated, quite lengthy assessment process that's mandated by the regs in the mental health system. And so the answer is absolutely not that if you're billing, if you're doing an assessment and that's getting billed through the prospective payment system, it does not need to be as complicated as the specialty mental health assessment. We'd be talking about setting reimbursement rates for both mental health and Fqhc. So what happened, it's really quite simple. On the Fqhc side, your rate is your rate is your rate per encounter, basically regardless of who provides the service, and it's a certain amount per visit, until you do a rate change, which is part of the scope of project change. And it's very similar to doing a short-term Medi-Cal cost report to do that rate change. And then, of course, I'm sure that most of you know that the way that rates get set on the specialty mental health side is you do your cost report, you have the whole process of the interim rate that you negotiate with the state that you get paid for. There's a scheduled maximum allowable that you can't bill above, and then there's a settlement process, 30 years later after everybody's retired. If there's any follow-up questions to that that I missed, please holler. Are you aware of any specific implications related to meaningful use? So, basically what's happening is the people in the health, there's a great deal of implementation of electronic health records in Fqhcs in California and around the country, and they're simply sitting down and looking at, saying, okay, we're in phase 1 that we're trying to get approved for, and they crosswalk the, what those phase 1 requirements are to what their clinical workflow is, and they're making sure that they're capturing adequate information to meet those requirements. I don't think that there's any problems with that. I haven't heard of anyone running across any problems. But John, if you have any follow-up question that's more detailed, please feel free to drop me a line or put it in the question box. Next question, can you provide an example of how one can bill for medical appointment and a behavioral health appointment on the same day? The only way you can do that now is that the medical appointment gets billed to the through the Fqhc, and then the behavioral health appointment gets billed through short-term Medi-Cal. And so what you're doing is you're billing two different systems. There's absolutely no problem with that. This may sound a little weird, but I think that it may be kosher to, if you had the patient see the medical provider in one clinic, and then like in the afternoon went to another clinic that had a different license, a different provider clinic number, I think you may be able to bill for that, but I can't remember. So I'm going to check on billing PPS at two sites on same day. And I'm putting together a list of follow-up that I'm going to be doing. One issue we've encountered is that many of our clients need to be seen by Fqhc psychiatrists and by short-term mental health staff, different cost centers. Our Fqhc payment system conflicts with our short-term obligations to fully assess. So in other words, you don't have to do this full assessment about this psychiatrist and the FQ. And so the question is, is it kosher to bill the mental health staff working in the mental health center billing through short-term when you don't have crossed all your T's and dotted all your I's around the assessment that was done by the FQ staff? We're toying with the idea of trying to break the assessment into a part 1 and part 2 instead of having to redo everything. However, this is a point of some contention, as even a thorough split in the paperwork may create a non-cost-effective situation for the Fqhc Behavioral Health Center. So this is a really, I think that this, you just, until things change around the enhanced regulation about what to do around an assessment, that may not be a bad idea. It's kind of clunky, but there's lots of clunky things that organizations do that are better than not getting paid or being afraid to bill because they're going to get busted on an audit. So as far as I can ascertain, I think that that's probably worth exploring. And then one of the questions is how does the documentation, if you have a partnership model where the behavioral health center is providing services and billing through short-term Medi-Cal, and the FQ is providing services and billing through prospective payment, how do those charts get shared? And that's a real tricky problem. People are all around California are working out all sorts of ways to share the information. Ideally, what would happen is you would, well, if you're not ideally, not quite ideally, is you would have an electronic health record where the information gets populated from both sites, both provider organizations, into one medical record, and there's patient releases that are done so that the Fqhc psychiatrist could do, quote, part of the assessment. The behavioral health side could finish the assessment so you could bill short term Medi-Cal. In Washington State, that's what happens is we have what's called a patient registry that's designed and operated out of the University of Washington. And people from the mental health centers and people from the health centers are both putting information into that patient registry, and it's available to both sides. And again, the appropriate patient releases have been collected. Last question before we go on to the next section, and again, please feel free to keep writing in questions. So, regardless of the service provided at the FQ and any given day, that service is billed at one rate. Only one service per day is billable. Yes, regardless of the service, it's billed at the same rate, and that rate is the PPS rate for that clinic. Different clinics have different PPS rates, and only one service per day is billable. It's really that simple and in many cases problematic. Right now there's a committee at the California Primary Care Association made up of representatives from health centers that are working on thinking about the question, what's next? What comes next after the prospective payment system in California? The way that the federal law is written, a state can say, we're going to stop using the prospective payment system and we're going to do something else. As long as the providers at the health center are getting as much, at least as much revenue from the new design as the old design, it's okay to do that. You don't need to, there doesn't need to be a change by Congress to change the law or a change by HRSA to change the regulations. And there's a committee that's been working on trying to figure out what comes next for the prospective payment system. And it might be, I haven't talked to anybody yet about having any behavioral health folks be involved in that process, but that actually would be a very useful thing. And so what I wanted to do is explore some of the issues that some of the new models that are being used in other parts of the country and in California outside the public system, so you can get a flavor of what might be on the horizon. And my first slide, is California is so fee-for-service centric, which is not the case everywhere you go. And if you read anything about healthcare reform on the payment side, all the brightest bulbs out there are saying that fee-for-service is dead, or fee-for-service is dying, fee-for-service is going to go away. And so the question is, what's going to replace fee-for-service, and what are the implications for those of you on the call? In many places around the country, people are experimenting with what are called transitional payment models for primary care clinics for health. And the general rule of thumb is you need to get accredited by NCQA, the National Committee for Quality Assurance, as a patient-centered medical home. So like the JCO process or the CARF process, there's an NCQA process to get accredited as a patient-centered medical home. And then what states are doing is they're saying, once you get accredited, we're going to put in place a transitional payment model. We will pay you a case rate for those kinds of services that Dale's been moaning about on this webinar that are the kind of things that you don't easily get paid for, or there aren't codes for it, or the provider can't bill, or et cetera, et cetera. So one of the ways to fix all of that can't bill for problem is to simply say, you know what, there's a lot of really cool stuff that's done to help people move towards health, to help people manage the chronic health conditions that are sometimes very short in duration, sometimes very not provided by a licensed person, that are incredibly value added. And what we're going to do is we're going to estimate the cost on a per patient per month or per member per month basis. And we're going to basically say, okay, so you have 100 people in your clinic that have asthma and 200 people that have diabetes and 50 people that have asthma and diabetes. There's actually these risk adjustment models where one can compute the acuity level of the patients in your primary care clinic and then come up with a dollar amount to say, for the 10,000 patients in this clinic, there's X, the average acuity level is 3.5. And what we're going to do is we're going to cut and you need these many full-time equivalent non-licensed, non-doctors, non-nurse practitioners, non-physicians assistants to provide these services, and we're going to cut you a check every month to pay for the costs without having to do the billing for that. It's happening already in a number of states around the country. In this transitional payment model, fee-for-service is paid for the doc, the nurse practitioner, and the physician's assistant services. And that could be the prospective payment system or the regular, fee-for-service CPT code payment system. And then the third layer is a bonus layer. And if you're saving money, the total health expenditures for your 10,000 patients is lower, even with the addition of the case rate, because you've become a hospital and institution prevention organization, and you've got people out of the emergency room, out of the hospital, out of nursing homes. You get to share. You get a share of the savings, and there's a lot of projects around the country where the clinics are actually getting half or more, half to 75% of the savings that that have resulted from this much richer wrapping care around people model. So that's one of the models. So it's in the future. What's really critical about this model is the focus. If you really, it's moving from a sick care system where you only get paid after people get sick to a true healthcare system. Because if you help keep people healthy, that's going to translate into lower emergency room visits, lower inpatient costs, and so you're actually getting paid, in essence, for helping keep people healthy. And if you're a community mental health center or a county mental health department that's working in a partnership model, it's very possible that the payments for your providers who are embedded in the clinic won't come from the prospective payment system. If we can get this built into the Fqhc system, it'll come from the case rate. You won't be billing Shordell, you won't be billing PPS. There's actually this other funding stream coming from the medical side that will pay for the nutritionists and the nurse care managers and the behavioral health clinicians. The next generation is how I pay for my medical care here in Seattle, which is called a subscription health home payment model. And this is basically transcending, it's moving totally away from a billing widgets model. And so at Qliance is the name of my provider, we're using a monthly subscription approach to healthcare and going directly to our patients to provide the most comprehensive, high-quality primary care out there. So what happens is the individual, the employer, or Medicaid pays the practice, the primary care practice, a monthly subscription fee for each patient who signs up. So I signed up with Qliance, and in my case, I have them do a direct deposit withdrawal from my bank account and deposit into their bank account, and they have no billing department. They have no claims adjudication department. What's happened is they've decoupled primary care from insurance. And so basically what they've done is they've pushed everything, they pushed the fee-for-service payments into the case rate. So they've combined the orange and the purple. And then in some settings there's a bonus layer, in some settings there's not. And so a lot of people are saying that the future of payment for primary care is this per patient per month. And the future for payment for behavioral health is a case rate. It's also known as a bundled payment. So what folks are basically saying is for inpatient care and for specialty care, they're predicting that we move towards a bundled payment or a case rate. So in the case of a hospital, what happens is the hospital costs, the physician services get bundled into a single payment for the admission. And the other thing that happens is that if there's complications, like somebody gets an infection from knee surgery or somebody gets pneumonia, that they don't get the bill for all, there's an acknowledgement that there's going to be some complication rate, but they're only going to pay for some of the complications. And if you have a higher than average complication rate, you lose money. If you have a lower than average complication rate, you make money. And it also includes all costs after the discharge for either 30, 60, or 90 days, depending on the condition, so that if a person gets readmitted to the hospital, guess what? They don't get paid a second payment. There's a number of places around the country where behavioral health providers, especially behavioral health providers, are paid on the case rate. I actually designed a case rate system here in Seattle in 1993 that's still being used. And in that case, what happens is there's a case rate that's paid for each person. It's a monthly case rate as long as the person's still in care. The mental health center gets a check for that person. And there's 3 different payment models, basically depending on whether they have a low level of need, a medium level of need, or a high level of need. I want to say a couple things about the bundled payment. They said, okay, we're going to set a case rate for a year's worth of diabetes care management. And what we're going to do is we're going to compute what ought to be happening in the primary care clinic or the specialty clinic to manage the diabetic, the care for the diabetic. And the second thing we're going to do is we're going to look at all the things that happen to people with diabetes, all the complications, emergency room visits, infections, diabetic emergencies, blindness. You can see the list. And they actually, and you can see that next to each condition, they actually imputed a dollar amount for the population that they were studying. These are huge data sets that they're looking at. And they basically said, okay, so for people with diabetes, this is the kind of stuff that happens to them, both in terms of occurrences, how often it happens, and the costs. And what they do, when they build the case rate, they say, we're going to pay you for the typical care, which is what people ought to be getting to treat their diabetes. And then we're going to pay you for half of these potentially avoidable complications. That's what PAC stands for, sorry, potentially avoidable complications, so that if you have higher than average complication rates, you're on the hook for it. This hasn't been developed yet for mental health centers, but it's a piece of it's something that is definitely evolving in the medical side and probably coming to the mental health system of the future near you. There's another question that I want to read out loud and see if I have anything useful to say about it before I move on. We're in the process of transitioning our impact program to primary care Fqhcs out of MHSA. Our challenge has been the specialty mental health paper for Medi-Cal compliance has been so time-consuming and has bottled up our ability to provide services, so much assessment. What is the requirement for documentation under the Fqhc? I have not seen any statutory requirements for what an Fqhc needs to do around documenting and assessment. So let me say that a little differently. If you go to your doctor, let's pretend that everybody on this call has Medi-Cal, and let's pretend that everybody goes to decides that you want to get a new primary care provider, and you go to that primary care provider, and we all go tomorrow for our first visit. And that first visit is a comprehensive exam where the doctor does the full meal deal, getting acquainted and filling out whatever paperwork they fill out. The question is, what are the documentation requirements for that doctor for that comprehensive visit? And the answer is, there is no such thing as requirements. Except for the fact that you have to basically complete enough documentation around the case to demonstrate that it really was the patient had the need for a comprehensive visit and to audit those charts. They don't have a checklist or a sample form that says, here's what I'm looking to see that all these things got completed and that, or this form got used. And it's the same thing for psychiatric services on the medical side. It's the same standard of care. It's not a these are the fields and these are the forms that you need to use. It's a different world. One minute's talking about the customization of the medical home. A number of you may have already heard me talk about group health. If you have, I apologize for repeating myself. But group health is in Seattle. It was started after World War II by a group of Quakers with the idea of, let's work together, let's pool our money together to create an insurance company and a delivery system that we own. So it's a cooperative, it's owned by the members. And group health has a long history of providing preventative care and good primary care, but little by little they became more like the rest of the sick care system, and they found that by the turn of the century, they were more expensive than most other places in town. Most other health plans, and you could buy insurance. So what happens is it's like Kaiser, and so basically they're more expensive, and they said, something's wrong with this picture. So, and they weren't real happy with the level of primary care that was going on. So as you can see from the screen, they moved to the first three buttons. They moved to moderates, and you could do same-day, next-day appointments, and you can also. But the problem with that is they asked the clinicians to do more. They didn't hire anybody else to field these emails or to get people in same day, next day access. And there was a high rate of clinician burnout. And also their quality scores started going down. So what they realized is that they needed to do a much more robust medical home. And look at what they added, the number of staff that they added. More docs, more nurse practitioners, physicians, assistants, more RNs. They're coming in more pharmacists. There's a new role for pharmacists in the healthcare environment. And they blew up their appointment schedule, which were 15-minute slots, and they made everything 30-minute slots. And so this health home, and it turns out that they broke even in the first year by reducing emergency room and inpatient. And they actually lowered as medical inflation kept going up higher than the rate of general inflation, they lowered their per member per month costs by $10.30. So the moral of the story is if you're really going to operate in a medical home, a health home environment, you have to spend more money on primary care. If you're going to do a good job with behavioral health primary care integration, you have to push even more money into the primary care clinic to support that. And right now, the models, there aren't enough places around the country that are adequately funding primary care, and everybody's going, well, why are we having such high healthcare costs? It's like a duh. And so a really critical piece of the puzzle is the FQs are underfunded in the same way that the mental health centers are underfunded, and until we fix that problem, we're not going to fix the healthcare system. But group health doesn't do a great job with mental health and drug and alcohol treatment. And so if you have folks in the safety net, like a mom with depression and diabetes, there's no way she's going to be able to manage her diabetes if her depression's out of control. And if she's the head of a household of 3, she's lost her job, she's experiencing domestic violence, her kids are on the brink of homelessness, holy smokes. The social determinants of health is absolutely critical, because people who are being affected by the social determinants of health generally are poor, they have poorer health status, and they have higher health care costs. And so we really do need to connect the head to the body. And so the future, I want to suggest to you that the future is not in medical homes, but the future is that's a one-size-fits-all. The future is in the customization of the medical home. And so what folks all around the country are doing is they're saying, you know what seniors in nursing homes need is different than youth and families on welfare, is different than adults with a serious mental illness. In these person-centered healthcare homes where you have mental health embedded in the mental health centers, like is happening in a number of places around the state, it's one of many designs that's being used to improve quality and bend the cost curve. So primary care clinics are coming to mental health centers more. That rate's going to increase. It's very, very important that everyone really think about the clients that you serve, and not just treating their head or not just treating their body, but thinking holistically about the care plan needs to think about what that person needs to move towards health, including their housing needs, their food security needs, etc. And so this idea of bi-directional integration is illustrated by this slide, where you have the behavioral health as an embedded medical clinic in the same way that the primary care clinic has behavioral health folks embedded in that clinic. A third example is in Atlanta, and what they're basically doing are they're moving beyond medical homes, and they're moving to what I would call health and wellness centers. This is very exciting. I think the future is not in medical homes. The customization of the medical home is necessarily going to create health and wellness centers that are customized for the needs of the neighborhood. So if you look at the list, well patient care, sick patient care, OBGYN services, etc., WIC, oral health, behavioral health, employee assistance, disability and voc rehab, foreclosure prevention services, etc. I did a site visit, and they have a farmers market every Wednesday. There's a wonderful community garden in a woods right next to the clinic where there's a walking trail. And for me, looking at this is this multidisciplinary one-stop shop that thinks about the health and wellness of the patient, and they're not really patients, they're community members. Helping people move towards health is where the future is going. And what I would suggest to everybody on the call, that is, you're thinking about the future and really trying to demonstrate that you are a valuable asset to fixing the healthcare problems in this country. If you look at this list, what's really interesting is if you all worked for a health center, you would have very few things on this list. But those of you that work for mental health centers, you actually have a lot more of these services because of the kind of clients that you've been working with than a typical primary care clinic. So I really think that the behavioral health community is going to be weighing in a lot around helping fix the healthcare system by helping create these one-stops. And I wanted to end the two sessions with this picture of the future because it's a very optimistic picture from my perspective. From this is what people need, and behavioral health centers are actually closer to having this picture fully laid out. They just don't have the medical services than many primary care clinics around the country. So on that note, let me see if there are other questions that folks have. I'm going to go into a cone of silence again for another minute, and then we'll take the questions. I'll say a few more words about what's next, and we'll sign off for the day. So I'm going to start my stopwatch now and come back in a minute. Don't see any more questions. I've got a list of homework assignments that I'm going to put together and package up and get out to folks in terms of some of the things that I didn't know the answers to. And we're going to be sending the slides out to everybody. And please feel free to email me if you have any questions. I have a contract with CIMH to help anybody in the small counties that are working on integration projects to provide any kind of direct consultation to you. And my email address is dale@djconsult.net. So feel free to tap into that pot of money and get some help if you think there's anything that I can do to help you. And if I don't know the answer to your question, I will point you in the right direction. Thank you, everybody, for spending 77 minutes with me today. And have a great rest of the day, a great rest of the week, and a nice weekend. We're going to sign off now. Take care, everybody.
Thanks, everyone. Thank you, Dale.
Thank you, Shoshana.
Bye.
Bye-bye.